Objectives of today's talk are really that we want to know what happens in those last 10 minutes. I think that what you're setting up is favorable conditions for healing. How are we going to examine the role of that, as well as what we do in the clinic post-operatively for debridements? Everybody has a different schedule. I'm going to tell you what my techniques are, and everybody's going to be a bit different, but I think that the central messages are the same. The idea is that we're going to focus on the procedures. There's also medical therapy, which I talked to you about identifying what the problem is and about the identification of what type of disease you're dealing with, and therefore you're going to have to use medications that suit that type of disease. Prednisone for the eosinophilic population, or some form of steroids, topical, Propel, anything that you're going to drug-elute, antibiotics or antifungal agents, betadine, things that are going to help you with infections for that non-type 2 or neutrophilic group. Comprehensive sinus surgery has really so many different things that you're trying to do. You're trying to accomplish is that you're trying to reduce the inflammatory load. You're trying to take away all the walls that have polyps growing on them. You're going to improve topical medication delivery by creating flushable cavities. The problem is that really turns into a controlled destruction of the sinus cavity. I showed you the extended uncinectomy. You're creating a lot of tissue damage there when you're doing that. You better have a plan about how to make that heal, because you want it to heal like that. Because if you don't do anything, it does not heal like that. The body tries to contract all the doorways you create, and it's going to try to pull on that turbinate to lateralize it. This is a view at the end of sinus surgery. What I thought about it is so telling about this, I think, is well-performed sinus surgery, but look at all the healing that has to happen. When we look up towards the frontal, I'm happy that all the spaces are aerated, the skull base and the orbit are skeletonized. But every cut surface is bleeding. You can see where we have to make a commitment to have that heal. Will it heal like that? And I'll tell you that unless it does, you won't be able to get to how you get these cavities where you can see each of those septations skeletonized from the skull base and the orbit. We need to make a commitment to getting there, and there's a whole bunch of pieces that go along with that. To do that, we have to first understand wound healing. What we realize is that in those first 10 days, it's that early inflammatory phase when they tell you they have a cold after surgery, I developed a sinus infection. That's just the lining angry at you for cutting into it. That you get lymphedema that happens over those first 30 days, and then you get mesenchymal transformation and maturation of scars that happen after 3 months. It means that those first 30 days are where you have an opportunity to intervene, that's the area for us to be able to control that inflammation both medically and procedurally, and we're going to talk about it. And hard to reverse once you get to 1 to 3 months out. You've got scars that mature, and you're going to have to do something different at that stage if you want to fix it, like revision surgery. So we don't want to be back at revision surgery. We want to understand that the crusting is going to happen the first 2 weeks. You're going to have granulation tissue happening over that first month. You're going to have significant amounts of swelling that improve over the next 2 to 4 months. And that the neo-osteogenesis of that raw bone happens at sort of that 1 to 3 month mark. What we really need to do is intervene in that crusting and granulation phase to make sure that it doesn't turn into that neo-osteogenesis. Well, what happens when you don't have controlled healing? Well, you get synechia. That's essentially bridging of two scarred areas. Osteal stenosis, if you actually get circumferential injury to an osteum, you know that it's going to try to close. Lateralization of the middle turbinate, the exact opposite of what I told you was important about our front door. And neo-osteogenesis, the hyperostosis of that frontal recess, where I told you we didn't take away those septations, but we just stripped them. What do we do to create optimal healing cavities? Though what we do is we make sure we have mucosa that's has good integrity, either by transplanting it or protecting it by stenting, which is what I'm going to show, and that we make sure the middle turbinate position is in a positive position. We can keep it medialized against the septum. You're going to be able to achieve what you want. And so this is about mucosal preservation, which I showed you before, but just again to think about that's how we get to those hyperostotic bone formation pieces and poor outcomes like this mucosal. This is where the transplantation of that uncinate process mucosa can be used in any areas that you identify as raw, and transplant them back in that area so you don't get crusting, granulation, scarring, and pain in those areas. More importantly, we're going to switch gears and talk about middle turbinate lateralization, is that we want to stabilize those middle turbinates. And so you can see in these two scenarios, this is what's happened in this revision population of the middle turbinate has become lateralized, scarred itself to the orbit, and resulted in complete downstream obstruction of the sinuses. What that looks like endoscopically is this. How do we avoid that? I told you that, no, I didn't mention this before, that middle turbinate lateralization, probably the biggest predictor of failure in sinus surgery, that people who have a lateralized middle turbinate have a twice as likely to need revision surgery. And so that's something, if there's one thing you can avoid, it would be that. This is the pathogenesis of how that happens. It scars over, then granulation tissue, then obstruction, then a deeper seated infection that happens. Middle turbinate suture stabilization can happen through suturepexy. You can suture it. I'm going to try to show you that. Middle meatal spacers of any kind. And so you can use anything from a finger glove to something that is going to pack the sinus from all sorts of molecules now that we have that allow for dissolving middle meatal spacers. You can try to control a synechia. We heard a shout out to Bill Bolger a couple times, and this one called Bolgerization, injury to the portion of the inferior part of the medial aspect of the middle turbinate, and an injury to the septal mucosa to encourage a synechia on the side that you want to pull open that front door of the sinuses. And then bioresorbable implants, obviously being a very nice way of stenting it, but not blocking the sinuses and allowing you to use flushes in that healing phase, but also have something that elutes steroids to the places that it touches. And so really nice ways. I'll show you my ways because I'm Canadian and so is Stacy. So we both have to come up with novel ways about trying to think about healthcare system utilization and expenditure, because things like Propel are not a reality for my practice. And so I need to find different ways to do that. One is that I suture a lot. I keep the middle turbinate sutured to the septum. Two is that I use silastic stenting techniques because, and I'm going to tell you why I use them in a whole bunch of different scenarios. What I do with the sutures is that when I perform sinus surgery, I 80+% of the time perform septal surgery with it, because I told you that those outcomes are better. No matter how badly or not so badly deviated your septum, your outcomes are better. And then I 2-point fix the middle turbinate. I use that straight mini Keith needle on a 4-0 plain gut suture, and then suture it through and through the septum twice, so that when you pull on it, it doesn't torque and make a weird angle. It just keeps it flat against the septum, and you'll see me pull tight on it now. And the inferior portion of the septum, the inferior portion of the middle turbinate is pulled over without obstructing the olfactory cleft. And then these are the middle meatal stents that I create. I'm going to tell you why I create them and what they're aimed at doing before I show you some more videos. They're, I think, a powerful technique, and they are really just based on this silastic sheeting. This, in this case, is made by Medtronic, but I think I know a million different companies that make them. They're inexpensive. I think they cost me around $11 or $12, maybe $15 with inflation, someone was telling me. That they are done out of two different thicknesses, a 1 millimeter thick and a 0.5 millimeter thick, and I'm going to tell you the scenarios I use the different settings. And why do I use them? They allow for flushability. I just took all this time to open up your frontal sinus, and then I'm going to pack the middle meatus full of something that lets them not ventilate air, not exchange air, and not let flushes into them. Doesn't make any sense. And so I'm going to also cover those raw surfaces. Each of those little raw surfaces that I showed you, if you can put some kind of dressing over top of it, like this creates, then I think you're going to allow for healing of that cut surface during the healing phase. It's a scaffold for remucosalization. I really believe in those areas that I've stripped that I don't have anything to put back onto. It captures moisture beneath it, and it allows the detrimental effect of airflow not to be on there. The airflow is what leads to the crusting. When you put silastic on something, the crusting goes dramatically down, if not to zero. It prevents middle turbinate lateralization. I'm going to show you how it does that by just shaping it in a specific way that it acts like a spring, and so it springs it open. It's inert, and so although it is not completely inert, things can't grow into it. Biofilms can grow onto it, however. So just, it is inert, and so it can be left in for weeks, but you got to be worried about biofilm formation on it. It delays my first post-operative visit, and that was part of the big challenges, that when you're operating on 20 people a week and you're starting to get to, or 20 people a month, and you're starting to get to the place where how do I fit in all these post-op visits, I couldn't do it. And I needed to make it so I didn't see them at 1 week, 2 weeks, 4 weeks. I see them for the first time at 4 weeks, and I'm going to tell you how, because while I'm keeping these stents in place, they can flush, and they're pretty well tolerated. Okay, so the design of these middle meatal stents, I'm going to show you just so that it makes a little bit of sense. It won't completely make sense, but these are just the cuts that I make. They're really designed to cover all the area of the ethmoid complex without obstructing any of the sinuses. So the idea becomes that I fold it up. I don't know if I have the video of me cutting it up, but I might. When I fold it then to put it into the nose, it looks like this. This is looking from the AP dimension, this is looking from the side, and this is looking from the top. What you see is that there's a way for the flush to go in the front, and it goes all the way back to the posterior ethmoid / sphenoid. There's a way for it to go through the top to get into the frontal sinus, and there's a way to go through to make the maxillary sinus open. I slide them in so it acts like a spring on the middle turbinate, and then has a way for the max sphenoid frontal to all ventilate while it drapes the entire ethmoid complex. And so this is middle meatal stenting, end of the case, anterior ethmoid artery identified, frontal sinus horseshoe shape identified, trying to get to the place where we can improve healing and allow for this sphenoid open. This is that shaped middle meatal. It's acting like a spring because it's 1 millimeter thick and it just springs itself open, pushes the middle turbinate against the septum. It's also been sutured, allows flush to go up to the frontal, sphenoid, and maxillary sinus without obstructing any of them, which is why I can leave them in for more than a week. That 4-month post-op, it still has some inflammatory reaction because the stent itself creates an inflammatory reaction. You do have a foreign body in the nose, but it is keeping it it's keeping it open while it does that. The difficulty with stenting is that you have to put everything together. So the reason you're able to do this is that I didn't leave partitions on the skull base, because if I did and I put in a stent, then it would encourage scar formation. It acts as a bridge for remucosalization. If you don't do complete comprehensive ethmoid surgery, you cannot use these stents because it'll create more problems than that would create more problems than it would solve. Stenting, the other challenges are that it sometimes can become displaced, and so it can obstruct the maxillary sinus if it slides down, and it therefore creates a bridge. It's time dependent, and so the longer you leave it in, the more inflammatory reaction it creates. And so this is just going to give you an idea of the post-op protocol that I use. Is that I told you that I use medical therapies based on what we saw, oral steroids and or oral antibiotics in the two different scenarios, and sometimes both, most times both, but sometimes I use more antibiotics, sometimes I use more steroids based on what I think is happening, and steroid impregnated saline irrigations. The big goal here is, because I can't put in something expensive that elutes steroids, I put in something inert and hollow that lets me deliver steroids through the rinses. So in that, they start that immediately post-operatively. We're going to change gears now and talk a little bit about post-operative debridement, because I think it goes hand in hand here, is that it's critical to long-term success. There's a pretty good evidence that from ICAR that that's our opportunity to intervene and reset that inflammatory progression, divide synechia before they mature and create long-term scars. And that in that first post-operative phase, there's impaired mucociliary clearance. The cilia do not work well when the lining is so inflamed. And so what you have to do is you get this stagnant blood and mucus, and your ability to debride it out is what creates that improvement. That debridement means that there's often poorly placed healing tissue, the granulation tissue, which is blocking a part of the max, or a synechia between the middle turbinate and the maxillary sinus. That is your opportunity to easily divide it in clinic. Requires rigid endoscopy to do so, but then you don't have to take them back to the operating room. What we see from a Cochrane review about debridement is the number needed to treat is 5. You have to treat 5 patients for 1 to avoid an adhesion. That's pretty significant numbers. And so you'll see that even in a split nose study, adhesion formation was significantly lower in the debrided patients. What does that debridement schedule look like? Everybody, and I'd be interested to poll the people who did rhinology fellowships there, remember their 1 week, 2 week, 4 week visits. Well, that turns into a lot of visits. And so I see people from all over the province. For me, those 20 post-operative patients each month turned into 60 or 80 visits a month. And it made it so that they were traveling from quite far to do so, and for me to generate that many appointments to see them was difficult. And so, by putting in silastic stenting and using saline irrigations, it delays that first post-operative visit, and they auto-debride themselves for 4 weeks, getting out all the old blood and debris and stagnant mucus, and the removal of the fibrin and clot. And so that first post-operative visit happens at 4 weeks, and we can intervene at that stage, divide synechia if there were any that the silastic wasn't covering. And then our second post-operative visit is usually at 3 months, so that we can get good results, but only seeing them 2 times in 3 months post-operatively. Successful debridement really requires about setup. You have to have an endoscopy tower. You have to have a video screen, unless you want to get your face very close to the patient with a rigid endoscope. You need to have a setup of equipment to do that. Here are rigid endoscopes of 0, 30, and 70 degrees. I rarely use a 70 degree, but we do have some in case some frontal sinus issues come up. We don't even really use 0 degree scopes. We use 30 degree scopes for everything because they're the most versatile in the clinic. And then having olive suctions, through cutting instruments, some graspers, and then some miscellaneous. I do have antral punches for the maxillary sinus, backbiters for those scenarios, and you need them. You need to topicalize the nose. Either in our clinic, that's a combination of cocaine and Otrivin, or lidocaine and adrenaline. I like the tetracaine gel. If we can get it compounded, I think that would be a really nice one. Something that you need to do to topicalize the nose to avoid vagal reactions. You could inject in the clinic and then pack the nose. I just think it takes time. I don't think it's hard to do with a rigid endoscope, but it takes time. And so injection in the exact same spots as you would for the start of surgery at the armpit of the middle turbinate, and then along the maxillary line lets you do anything anteriorly within the nose. Once you make this injection, you'd be surprised that you can do a maxillary antrostomy in your clinic with the appropriate setup. The practical steps for me are that I inspect the nose and then remove the stent, and then I use an olive suction to suction into each cavity, frontal, maxillary. I usually just visualize a sphenoid because they're usually quite large. And then I debride any scar tissue as required. I'm going to show you some pictures. Here's removal of a middle meatal stent. We're going to visualize that stent. You can see that it's sitting in the middle meatus and it's tucked up under that armpit. You can see some goo in the side of it. So it's not that it is totally clean, but it's pretty clean. You can see right up to the frontal sinus with the stent in place. And then some crusting that's happening around it. On the other side, the exact same thing. We're going to try to visualize the entire thing, see inside it, and see if we can see the sinuses. You grab it with a straight grasper. You pull down because it's anchored behind the anterior buttress of the middle turbinate, and then pull them out. They get tolerated very well, pulled out in the clinic. And so what you see is when you go back, that we're seeing some of the stent reaction. There's some irritation of the mucosa. You can see it along the orbit. There's some stray mucus and crusting that has happened, but the sinus doorway is open after a month, and that we're going to cannulate those with a suction to make sure that any mucostatic debris is being removed. Here, some polypoid change along the orbit, because that's where the stent was sitting. You can see that it's created a bit of a stent reaction that now will stay open, though, and allow for medication delivery into the max, sphenoid, frontal, ethmoid, and so I'm pretty happy with that. From a frontal sinus inspection standpoint, we're careful to go up with an olive suction to make sure I can see and debride anything. You can see there the frontal sinus open, but maybe not as big as we'd want it to be. Cannulating into it and kind of breaking that with circumferential pressure. I find that I can squish some polyps, and that makes a difference, but it's just part of our normal routine to at least cannulate the sinuses so we know that they're open, and now the medication can get into them postoperatively. Here, early healing cavities with synechia. Here you can see one very commonly at the anterior edge of the maxillary sinus, because the maxillary sinus is like a paisley shape or bent pear, and so that's a common spot to have a narrow place where synechia can happen. Across the ethmoid cavity, you can see that kind of healing cavity. Here's just mucostasis and edema, blobs of mucus and edema of the lining. That will get better with time and topical medication. And then just polypoid mucosa as well as things you can see. Debridement of synechia, I just thought I'd show a couple examples. You can see that this is your opportunity. This with either topical medication or injection, and you can do both based on how your patient is doing. You can see we can take straight through cutting instruments, always cutting, not grasping instruments, because they can't feel you cutting these synechia. They're not sensate, but if you grabbed them and pulled on the mucosa they're attached to, that is sensate, and they will be quite upset. And then using backbiters to do that. So all through cutting instruments, you can see that from comparing the beginning where we had kind of like a stellate scar of the maxillary sinus to the end of that's the two kind of pictures that you're looking at. That is a worthwhile intervention at the 1 month post-op phase. Here's another one, easy one that I told you about, happens pretty commonly in the maxillary sinus, and so we just use a backbiter to remove it to prevent recirculation, not have to go back to the operating room. That scar is not even mature. Making sure we do an extra good job for the video by taking a straight through cut to the top maxillary sinus. So there's before and after, small in-office procedure, no injection in that scenario at all. And so we saw a couple scenarios, both of what happened pre and post. I'm going to see if I remember this video about a middle turbinate adhesion. Sometimes if you size this stent wrong, or if you're packing, when you packed it, didn't get in, is that the middle turbinate bottom edge can pull onto the lateral nasal wall. I'd encourage you to divide that, because that's something that will continue to pull at that turbinate. The challenge becomes dividing it sometimes leaves two raw edges. And if you're not putting anything else in between, is it going to stay that way? And so when I do divide this, I try to create as much room as possible. I understand that it's going to allow for better medication penetration into the maxillary sinus, and hopefully will stay divided when you did that at the 1 month mark. Synechia that cause recirculation, I think we talked about this already, that feeling of obstruction and recirculation. They tell you I have a blob in my nose. Every time I rinse, it goes away, and then a couple hours later, it's back. And you look and you think, I don't really see anything. That little blob of mucus that's sitting around that recirculating band in the maxillary sinus is the culprit, whether anterior or posterior. And so if you simply divide that synechia, they don't get that, and the blob is gone. It's a common thing that I think gets overlooked quite significantly. If it happens in the frontal recess as well, you can see small adhesions that have come across there, soft at the point where you're seeing them. And so all we do is use through-cutting instruments in our clinic to divide those synechia. There's an upturned through cut. We have a 45 Heweiser as well, just to try to cut it both medially and laterally so that you can create that horseshoe-shaped opening bounded by the anterior ethmoid artery. Obvious disadvantages of post-op debridement are that you can get some epistaxis. You can have some vagal reactions in your clinic, so good to have a chair that goes flat. And they can have some pain, but I find that if you choose the patients right and inject the ones you need to, that you're going to get good success that way. I'm going to try to finish 5 minutes early because I'm sure there will be questions about what I told you about silastic and about debridement, but I'm interested to field those 5 minutes of questions and take any other comments or thoughts. Yeah, she'll bring you a mic. I can repeat your question, but she'll bring you a mic.
Did you guys study the silastic or not using it for these people from a distance? Because I think some of us that are in like the mountain areas where the patients are coming, not uncommonly, 2.5, 3 hours one-way journey to get to you because of windy roads. I agree with you. It's not practical to have them back a ton. And sometimes they have surgery and they just never show up again. They just kind of disappear into the ether. Did you guys try it with and without the silastic so that if they didn't show back up or whatever happened, weather is a big one, especially
great question.
Time of the year for surgery?
Your situation is much like mine in that people come from all over British Columbia to the Vancouver General Hospital. And so there's pros and cons to this, is that I think the problem is leaving it in forever can create a problem. I think the foreign body in the nose, surprisingly, part of what led me to do this is that there are some patients who didn't come back for 6 months, 8 months, and then my office kind of figured out, hey, this person's canceled 3 appointments. They've never been here since surgery. We got them back, and I was like, oh my God, this is gonna be horrible. This thing's gonna be infected. It has some slime on it, but the cavities are open. And the lining is angry because it has a foreign body in there, but it's not like it is horrible. And so that gave me some pause to think, maybe I can leave them in longer than I thought. Then we studied it. I published a paper on our pituitary patients where we raised a nasoseptal flap. We denuded the entire surface of the septum on one side. And then we put a piece of silastic in some, randomized, some people silastic, some people nothing, and kept seeing them back. And our thought was we were going to biopsy the mucosa at different stages to see what the cilia, the mucosa looks like and whether it was actually functional. What happened was the people who didn't have silastic had a mat of crusting, so crusted you couldn't even get at the lining. And the other ones, it was mucosa underneath the silastic. And so as we started to do the study, we extended it longer and longer and longer. And that's how I came to that 3-month conclusion about remucosalization. Anything that I drill, like you saw me drill the frontal sinus, when I expose bone and leave and if I just hurt the mucosa, I put it on for a month so that I can let the mucosa heal without having air to deal with, because air is the enemy. And somehow it's like a petri dish. It traps moisture underneath, and the moisture lets the mucosa remucosalize. If I drill something, I leave it in for 3 months to let the whole thing remucosalize. That's how long it takes mucosa to seemingly grow on bone. Good question. Yes?
How do you secure the stents?
Question was, how do I secure the stents? The answer is that the middle meatal stents are really cut to fit into the ethmoid complex. They sit at the anterior face of the sphenoid, and they're only long enough to sit behind the axillary, the buttress, the anterior buttress of the middle turbinate. So they slide up. They slide up and they're fixed in place. I would say one a year comes out. I don't know if there's any that really come out, but they don't come out. I think it's just more about sizing once you get good at shaping them and sizing them. The other way that I secure the frontal sinus stents, which I didn't show you, but I can, is similar to Nithin. I make a little cut at the top so that it has one little phalange that sticks out. So if it's ever trying to slide down, it just gets caught. It's like a tube, a cylinder with a phalange at the top, and that phalange just keeps it stuck in place. Any other questions?